Thank you all, and thank you for participating and being here today. It's really a pleasure to be able to speak with all of you. Again, I'm a medical oncologist. I specialize in GU cancers, including prostate cancer. And today, I'm going to talk about the systemic treatment options for prostate cancer. So this morning, we heard a lot about our local therapy options, surgery, radiation. But what if local therapy doesn't work? What if, when you're diagnosed, you're not a candidate for local therapy? So talking about the systemic treatments means the pills, the IVs, the injectables that many of our metastatic prostate cancer patients are on. So as an agenda, I'm going to review the disease states of prostate cancer to serve sort of as a roadmap to understand where we are. And then we'll talk about the treatment options for metastatic prostate cancer, breaking it down into hormone-sensitive metastatic prostate cancer and castrate-resistant prostate cancer, and we'll define that, in addition to ending with some exciting areas of active clinical research. So these are the 5 main disease states of prostate cancer. Fortunately, the majority of patients are diagnosed with localized prostate cancer, meaning the cancer is within the prostate itself. And as we heard about this morning, this is treated with radiation, surgery, and occasionally with radiation, we do give a course of androgen deprivation therapy. However, about 20 to 30% of patients after these local therapies develop a rise in their PSA. And we call this a biochemical recurrence. There are salvage surgeries and salvage procedures we use. There's also salvage radiation we use for biochemically recurrent prostate cancer. And now, for all of our patients who have biochemical recurrence, we use PSMA PET scans, as we heard about from Dr. Hong this morning, to diagnose and detect the cancer at a relatively low PSA. And we often find metastatic disease. And when we find metastatic disease in this setting, when a patient is not on androgen deprivation therapy, they have a normal testosterone, this is considered hormone-sensitive prostate cancer. So we're going to dive into metastatic hormone-sensitive prostate cancer and start to understand how we think about this disease state and the treatments that we use. So we'll start with a patient case. A man presents with fatigue, weight loss, and back pain. He's found to have a PSA of 140. He gets a prostate biopsy. We use a Gleason score to show that he has Gleason 4+3 prostate adenocarcinoma. And we get a CT scan that shows that he does have metastatic disease involving the lymph nodes and ribs. So this man presented, at the time of presentation, he already had metastatic disease. This is hormone-sensitive prostate cancer. And so we know for these patients, not all metastatic disease is the same. So we risk stratify actually based on the volume of metastatic disease. On the left is depicted low volume metastatic cancer. You can see on this bone scan a single isolated rib metastases. On the right is depicted high volume metastatic prostate cancer. This is technically defined as having 4 or more bone metastases, including at least one metastatic site outside the spine and pelvis. And we do this risk stratification because we know that the outcomes and the prognosis for these patients is very different, and we try to tailor our treatments to be the best fit depending on the volume of disease. We also know that having had prior local treatment, meaning having been treated with radiation or surgery, can significantly impact outcomes. So this is data that came out of Dana-Farber. They looked at all of their prostate cancer patients and looked at survival. And we saw that having had prior surgery or radiation and then developed metastatic disease, and specifically low volume disease, tends to have a better prognosis than high volume metastatic disease up front. And so this tells us that we need to tailor our treatments for our patients, to think about the presentation and think about the treatments we should offer. It used to be that we used androgen deprivation therapy for every metastatic patient about a decade ago. This still remains the backbone of treating metastatic prostate cancer. However, there's additional treatments that we've added. So kind of talking about androgen deprivation therapy is important because it's very common and many men experience this. It involves the complicated hypothalamus pituitary testes axis using various modalities, whether injections like Lupron or Eligard, or pills like Relugolix, to essentially deprive your prostate cancer of testosterone. Added to this modality of treatment are the newer agents, what we call novel hormonal therapies or androgen receptor pathway inhibitors like enzalutamide, abiraterone. And we'll talk more about the role of these treatments and in which patients we think about them. But before that, we should discuss some of the side effects of androgen deprivation therapy. So we know that men will experience many side effects on a day-to-day, fatigue, hot flashes, but we also know that androgen deprivation therapy affects other organ systems, can cause muscle mass, can cause bone thinning, can cause increased cardiovascular risk. So it's really important for our patients who are on androgen deprivation therapy, we monitor for these things and we manage them along with managing their cancer. And before the novel hormonal therapies that we'll talk about later, our landscape for treating metastatic prostate cancer really changed about a decade ago in 2014, when the charted GEDUC and STAMPEDE trials showed us that adding docetaxel chemotherapy to androgen deprivation therapy actually improved survival. And we saw this particularly in high-volume patients. So men who were diagnosed with high-volume metastatic disease, who were eligible for chemotherapy, started getting both androgen deprivation therapy, Lupron, Eligard, with things like with docetaxel chemotherapy. And so this was a major shift because previously we had been using androgen deprivation therapy followed by docetaxel chemotherapy instead of doing it in combination. However, more recently, there was 2 clinical trials, PEACE-1 and ARISENS, that showed us that maybe we should be doing even more. So in these clinical trials, we saw that the addition of one of the androgen receptor pathway inhibitors, specifically either abiraterone or darolutamide, to ADT and docetaxel chemotherapy showed a significant benefit. And so what we've learned is that for our patients who present with metastatic prostate cancer, who have high volume disease, and who are eligible for chemotherapy, we should consider triplet therapy. So that's androgen deprivation therapy plus docetaxel chemotherapy and one of these AR pathway inhibitors. So the role of these treatments is really changing, and you can see this trend where we're learning we should do more upfront, and it truly does benefit patients in the long run. This class of drugs has become very familiar in prostate cancer. These are the androgen receptor pathway inhibitors, and the 4 clinical trials that led to the approval of using these drugs with ADT. They're quite effective, and all of these drugs extend survival in a meaningful way. And so we know that for our patients with all volume metastatic disease, especially those with low volume disease in which we're not considering chemotherapy, we should add abiraterone, enzalutamide, apalutamide as potential agents to intensify their treatment and benefit our patients in the long run. So that was a lot of information, but to summarize, all of our patients with metastatic hormone-sensitive prostate cancer are risk stratified based on how much disease they have outside the prostate. What is it, low volume or high volume? And also whether or not there's someone who got prior local therapy and now have recurrent disease versus have high volume metastatic disease upfront. We also know that ADT remains the backbone of our systemic treatments, and it's really important to manage the side effects of ADT and the other organ systems that are affected by ADT. And in our chemo-eligible patients, since 2022, we're starting to consider triplet therapy. That's ADT plus docetaxel and another novel androgen receptor inhibitor. And if a patient's not chemotherapy eligible, we still know that we should intensify our ADT with something like abiraterone, enzalutamide, or apalutamide. So going back to our landscape, what happens to patients with metastatic hormone-sensitive prostate cancer? So we know that ultimately, metastatic castrate-resistant prostate cancer is a phase that all patients with metastatic disease eventually experience. And so we'll describe a patient case where in 2021, a 62-year-old man was found to have a PSA of 120. He has a bone scan. It shows 3 sites of metastatic disease in the hip and spine. So per the Latitude trial, he was started on abiraterone and prednisone with ADT. He has a good response over the course of about 2 years. And then in 2023, while he's on these therapies, he develops a rise in his PSA, and he has another scan that shows bony disease. And so this is quite typical, where we know that after starting patients on androgen deprivation therapy with some sort of intensification, they benefit for a period of time. And then after that period of time, their cancer becomes what we call castrate resistant. And so this is really an important phase of prostate cancer that we spend a lot of energy on research to try to develop better treatments for castrate-resistant prostate cancer. Listed here are some of the therapies that are approved, and certainly this landscape is evolving. Before we dive into the treatments for metastatic castrate-resistant prostate cancer, it's really important to note that all patients with castrate-resistant prostate cancer should be on some sort of bone supportive therapy. So we know as we age, our bones thin, we are at risk for osteoporosis, osteopenia. But having been on androgen deprivation therapy increases that risk significantly. And so we should consider denosumab or Zometa as bone supportive drugs for all patients with metastatic castrate-resistant prostate cancer. Of note, these treatments may require you to see a dentist because they do have a risk of what we call osteonecrosis of the jaw and require good oral hygiene before initiating. And in addition to these IV and sub-Q injections, calcium and vitamin D remain recommended to really support the bones for these patients. And then what about the actual therapies for prostate cancer? They're divided into, in the castrate-resistant phase, into 4 main categories. So number 1 are the AR pathway inhibitors that we heard about for hormone-sensitive prostate cancer. It's important to note that after having been on one of these agents in the past, the likelihood another one will work is low, less than 20%. But they include abiraterone, enzalutamide, apalutamide, and darolutamide. Chemotherapy, this is one of our oldest drugs that we still use very often for metastatic castrate-resistant prostate cancer. That includes docetaxel, cabazitaxel, carboplatin, and mitoxantrone. In a subset of patients, very select patients, there are immunotherapy options. So that includes pembrolizumab. However, we only use this for patients who on their genomic testing are found to be what we call MSI high, so microsatellite instability high. And then sipuleucel T, which has a modest effect in our lower volume metastatic patients. And then the last category is DNA damage. And this is an important category where there's a lot of research and ongoing development. So one of the older drugs, radium, 223, and then PARP inhibitors, where there's been several clinical trials recently for castrate-resistant prostate cancer. And then the last one is lutetium-177, also known as Pluvicto. So we'll talk a little bit more about kind of these last 2 DNA damage agents where there's been some recent development. So what are PARP inhibitors? PARP inhibitors are small molecule, they're oral drugs that are approved for the treatment of metastatic castrate-resistant prostate cancer in a select group of patients. There's 4 approved agents, niraparib, talazoparib, rucaparib, and olaparib, that fall into this category of medication. And before we think about using a PARP inhibitor, we always have to ask, did the patient have genetic testing? So for any man who's diagnosed with metastatic prostate cancer, we do recommend genetic testing for inherited cancer genes. That's because studies have shown that almost 11.8% of patients with metastatic cancer have inherited DNA defects, and so that's really relevant to our patients, but also their families. But beyond what's inherited, we also do tumor testing. So the reason we do this is because there's additional mutations that may be what we call somatic, so they develop in the tumor that are potentially relevant. And tumor testing can be done on any tissue, whether it's the prostate or a lymph node biopsy, and it can also be done on liquid biopsies, meaning a blood test where they look for circulating DNA. DNA changes over time due to the genetic instability of a tumor, and what's been seen is that 23%, so significantly more tumors that are metastatic castrate resistant have DNA alterations that may be relevant. And so we always ask for our patients with castrate-resistant prostate cancer, did they have germline, so inherited gene testing and tumor testing? And the reason we ask that is because the FDA has approved PARP inhibitors for castrate-resistant prostate cancer. We're predominantly using olaparib or rucaparib after patients have already gotten drugs like abiraterone or enzalutamide in patients who have one of the 14 HRR mutations, so specific mutations that we're looking for. There's also been approvals for these PARP inhibitors in combination with the novel hormonal therapies like abiraterone and enzalutamide. And the way we look at this is we know that they are truly most efficacious, especially in our BRCA1 and 2 mutated tumors. Let's talk about that next DNA damage agent, Pluvicto. So first, starting with a little bit of biology about what is PSMA. So we heard this morning from Dr. Hong about PSMA-directed scans, and theranostics is a growing area of prostate cancer development, and it uses PSMA. This is a protein that sits on the prostate cancer cell, and it's highly expressed in prostate cancer, unfortunately not expressed in normal tissue, so it can be used to diagnose prostate cancer, but also it's being used in therapies like Pluvicto for treating prostate cancer. You can see here this cell protein that lutetium-177 PSMA-617 uses. It binds with high affinity to that protein on the cell membrane, and then Lu-177, which is a radioactive atom, emits beta particles that result in prostate cell death. And so this therapy is approved based on the VISION trial, in which patients who had PSMA-positive prostate cancer and had been treated with an AR pathway inhibitor like abiraterone, enzalutamide, et cetera, and chemotherapy went on to receive either Pluvicto versus the standard of care. And what we saw was that there was an improvement in overall survival in this highly pretreated population of about 4 months, and the side effects were actually quite tolerable. They include fatigue, dry mouth, and some decreased blood cell counts, which are overall very manageable. And so this is really a growing area of development. There's several of these radioisotopes that are being studied to treat and target castrate-resistant prostate cancer. And so I think that the use of these types of drugs will kind of evolve in the next couple of years. And other exciting areas of development, we're studying immunotherapies. So you might have heard of CAR T-cell therapies that are being used for lymphoma, targeting PSMA, and also bispecific T-cell engaging antibodies. So these are antibodies that are taking advantage of PSMA and bringing the T-cell to PSMA so that your own immune system can fight and recognize the cancer. There's also other oral treatments like abiraterone and enzalutamide that are inhibiting the AR pathway, but actually by degrading the actual protein and inhibitors that are under development that are promising options for castrate-resistant prostate cancer. So in summary, all of our patients who have metastatic prostate cancer at some point will develop castrate-resistant prostate cancer. And we always have to think about bone supportive therapies like Zometa, denosumab for these patients. Our systemic treatment options include AR pathway inhibitors, chemotherapy, immunotherapy, and DNA damaging therapies. We always have to look back and see and make sure patients have genetic and genomic testing to make sure we can open up doors for potential PARP inhibitor therapies. And the role of theragnostics is very exciting and an area of development for these patients. And so I wanted to leave plenty of time for questions, and maybe we can start with the audience questions that Lori has.
Great, thank you so much. This has been very informative. So we do have questions on live stream and a few in person. And again, if you guys have questions, just go ahead and write them down. Is there a particular ADT especially suitable for patients with existing depression or anxiety?
Yeah, that's a great question. So we have many different types of ADT that work in different ways. So some of them are GnRH agonists, meaning they activate that hormone. Others are GnRH antagonists. And we also have injectable and oral forms. For some of my patients with depression, one of the things that I've tried is the oral form of ADT because of the fast onset and fast offset. So this is Orgovyx, also known as Relugolix, meaning it will suppress the testosterone quickly, but if there's any evidence that the patient's experiencing mood issues, depression or anxiety, we can also stop the drug quickly. And so that's been something that's very beneficial. I think also making sure that we use our multidisciplinary teams. And we know that ADT has a significant impact on mood, making sure that we are engaging our psychologists, our therapists, in addition to our psychiatrists, to help us to really optimize that important comorbidity before we start ADT.
I'm going to add on to that question. So when you do prescribe ADT, do you have a setup with the social service support system at Stanford? Do you connect people at that point?
Yeah, so a lot of times I'll recognize if my patient has anxiety or depression, and we will make referrals to our psych-oncology group and our palliative care group to help with that symptom.
Wonderful, thank you. A couple questions from live stream. Can you quantify the length of time to reach castration resistance?
Yeah, that's a great question. So it's different in every patient. With intensification, so the more intensified upfront treatment, it's years, fortunately. So it used to be 1 to 2 years, and we're pushing that beyond 2 years. Again, there's a lot of factors that impact when somebody reaches castrate resistance. I would say one of the most important factors is what we use in the hormone-sensitive setting and how intense that regimen is.
And then kind of along the same lines, when you become castration resistant, do you measure PSA by percentage, or do you measure it from the baseline, or how kind of is that determined?
Really great question. So when somebody becomes castrate resistant, we'll start to see an uptick in the PSA, and the most important measure is actually the doubling time. So how quickly the PSA is doubling. Generally, we say that a doubling time less than 6 to 8 months is of concern versus patients who have a doubling time of 1 to 2 years. And that helps us to understand how quickly we need to move to the next line treatment.
Does ADT increase breast cancer in men?
That's a really good question. So it is an anti-hormonal therapy. When it's acting on GnRH, it's also impacting other hormones. Overall, it wouldn't increase the risk of breast cancer. If anything, it would reduce the risk of breast cancer by making the other hormones that are available lower.
And then a question about LU-177. How come it is not used at the onset of hormone-sensitive prostate cancer?
It's a really good question. It's currently being studied in that setting. There's a number of clinical trials that are looking at abiraterone or standard of care that would include ADT plus abiraterone with Pluvicto, one that's called PSMA addition that recently finished accruing. So we'll see the results from that in the coming years.
You're full of such great information. Another question. You briefly mentioned, the brand name Provenge. And can you expand any more about what you think of the use of that? Is there any research work on prostate cancer vaccines?
Yeah, really great question. So Provenge and the clinical trial that led to the approval of that, when you look at the patients that were included, largely patients who had lower volume, less symptomatic disease. So I think there is a role. The survival benefit was modest, on the order of months, in addition to the PSA benefit. So we know that there is a role, but I think it's in a select group of patients who have lower volume disease, maybe a lower PSA, in which this immune treatment can be effective.
And then how come you use prednisone with abiraterone?
Great question. So prednisone acts on an important enzyme that's involved in the production of testosterone. Sorry, the abiraterone acts on an important enzyme that's involved in the production of testosterone, but also very important in the production of a natural cortisol. And so when we give prednisone with abiraterone, it's meant to actually replace your body's natural cortisol. And so you'll see that if you took abiraterone without prednisone, you might develop low potassium. That's because the hormones in your adrenal gland that are important for regulating potassium need to be replaced.
And a couple more. What therapeutic tactics are there for slowing tumor resistance to therapies by shifting treatment to all tumor to remain heterogeneous cells? To remain heterogeneous cells out, oh goodness. Competing with each other. Okay, let me try that again. What therapeutic tactics are there for slowing tumor resistance to therapies by shifting treatment to all tumor to remain heterogeneous cells competing with each other?
I'm not sure I 100% understand the question, but I think what you're getting at is kind of the natural progression of prostate cancer, which is we see that on any given therapy, there's a time frame where the tumor is actually sensitive versus when it becomes resistant. So one of the things that's happening in the trend of how we're treating prostate cancer is intensifying treatment up front. And so we see that when we use triplet versus doublet, the time to progression is much longer. And so while it's not acting, while it's not perfect, eventually the tumor does become resistant to triplet therapy. It is prolonging that time, kind of by using different modalities of treating the cancer all at once.
More question. I'm not sure I understand, so maybe if I say it, it might make more
Yeah.
sense. Is the 6 to 8 months doubling for castrate-resistant cancer not for doubling before getting Eligard or lupin?
Yeah, we use that threshold in both settings, actually. So the doubling time when you have a biochemical recurrence is relevant. And the other thing we use at the time of biochemical recurrence, well mentioned, is the PSMA PET to see if we can, there are strategies to use, for example, radiation to delay that doubling time. But it's also relevant in the castrate-resistant phase, where we know that at a shorter doubling time, you're at greater risk for developing new metastatic sites.
Great. I think that's everything. Thank you so much.
Thank you all for your time.